Hello, my name is Anne Graf-Ladisa, and today I will be talking to you about the pharmacotherapy of dyslipidemia. There are two guidelines that you should primarily be aware of with regards to treatment of blood cholesterol in adults, and they're the 2013 AHA Treatment of Blood Cholesterol Guidelines and the 2014 National Lipid Association Guidelines. So this slide summarizes the treatment approaches in the guidelines in a very simplistic way. The AHA guidelines offer a simplified approach for primary care practitioners in primary health care settings in the patients that they're most likely to see. The guidelines do abandon any numeric treatment goals for LDL cholesterol or non-HDL cholesterol, as we're seen in guidelines previous to the release of these AHA guidelines. And instead they focus on the overall atherosclerotic cardiovascular disease risk reduction. And they don't recommend non-statin lipid therapies as in combination with statin therapies. And we'll talk more about these AHA treatment guidelines in later slides. The 2014 NLA guidelines attempt to fill in some gaps that are left open by the simplified AHA guidelines. So they incorporate several specific patient populations that are maybe managed by generalists, but are also managed by lipid management specialists. And some of these populations include very high-risk patients like HIV patients or CKD patients, patients with rheumatologic disease, children and adolescents, and patients with diverse ethnic, racial backgrounds. And so to that end, they use a more complex and patient-specific risk assessment. They do use numeric treatment goals, such as LDL goals and non-HDL goals seen in previous guidelines, and recommend titrating therapy to achieve those goals. And then also they do advocate for non-statin therapy in combination with statins in patients who can't tolerate the statins or have non-LDL lipid abnormalities, so still being at ASCVD risk despite having achieved their LDL goals. So for this lecture, we're going to primarily focus on the AHA guidelines, as the focus of this course is in primary care. There's a lot to learn in this course. I don't want to overwhelm you with the two different treatment strategies. And really, most patients could likely receive overall appropriate therapy using the simplistic approach of the AHA guidelines. However, I would encourage you to evaluate the NLA guidelines to further understand the differences. And some practitioners have adopted a hybrid approach based on their practice site, and it wouldn't be unreasonable to incorporate the NLA recommendations for patients in which therapy is not straightforward using the AHA guidelines. In 2013, the American College of Cardiology and the American Heart Association jointly released evidence-based guidelines for the treatment of blood cholesterol. And there's some key concepts in these 2013 guidelines which I'd like to highlight that differ from previous guidelines that you may be familiar with. First, the focus of these guidelines are really on using treatment to reduce the risk of atherosclerotic cardiovascular disease. So you should note that these treatment guidelines are not for use with patients with complex lipid disorders. Those patients with complex lipid disorders should likely see a specialist versus a primary care provider. So for our purposes today, as primary care providers, these guidelines should fit the patient population that you would likely see and need to treat. Also, another thing that differs is that these guidelines do not recommend titrating drug doses to achieve specific LDL targets.
So this is because the guideline authors were unable to find evidence to support this practice. But previously, this is what we had been doing up to this point. So they felt that they weren't able to find this evidence and that treating to a target can actually result in undertreatment if an evidence-based dose isn't used, or could also result in overtreatment.
AHA guidelines note that HMG-CoA reductase inhibitors, or a group of drugs that we commonly call statins, are the drugs of choice for the treatment of blood cholesterol in adults. Now, there are 4 major statin benefit groups that are listed here on this slide. And there's 2 things that I want to point out. First, in the first group, clinical patients with clinical ASCVD. These are patients that have acute coronary syndrome, history of an MI, stable or unstable angina, coronary or arterial revascularization, peripheral arterial disease, stroke, or TIA. I also wanted to point out that the guidelines introduced a pooled cohort equation cardiovascular risk calculator as a way to calculate an estimated 10-year ASCVD risk, which you'll see under the 4th statin benefit group. So out went the Framingham risk score, and in went the use of this calculator, which we won't go into during this drug therapy lecture, but you can find this calculator online, or you can download an app for your smartphone that you can use to calculate an estimated 10-year risk. So patients should receive high or moderate dose statin therapy depending on which benefit group they fit into. And we'll talk about these high and moderate dose categories when we introduce the statins. So this slide lists the classes of drug therapy used to treat cholesterol. And as I mentioned, statins are the first line drug therapy agent of choice that are recommended in both the American Heart Association and the National Lipid Association guidelines. So we'll focus on statin therapy primarily in this lecture. However, we will briefly touch on the other agents as they are recommended in some patients in other guidelines and updates of these guidelines. I do want to note that remembering, even though this is a drug therapy lecture, remembering that including therapeutic lifestyle changes is a key concept in the management of ASCVD risk.
Statins work by inhibiting HMG coenzyme A reductase, which is the rate-limiting enzyme in the synthesis of cholesterol. It undergoes first pass extraction, and the primary effect of statins is on the liver where cholesterol is made. So by reducing this enzyme, HMG CoA reductase, there is a compensatory upregulation of LDL receptors on hepatocyte membranes, and this increases the catabolic rate of LDL. So what are our treatment options with statins to reduce cardiovascular risk? Well, as I mentioned before, the guidelines recommend that we use either high or moderate dose intensity statin therapy based on which of the 4 statin benefit groups your patient fits into, rather than treating to specific target LDLs. So in the top part of this table, the categories of high dose statin, moderate dose statin, and low dose statin are shown what the average LDL reduction is. So high dose statins on average will reduce LDL by 50% or more. Moderate dose statins will reduce on average LDL by 30 to 50%, and low dose statins reduce LDL on average by less than 30%. The bottom part of the table shows the statins and the doses that in randomized controlled trials when used, demonstrated a reduction in major cardiovascular events. So things I want to point out in this table as well is that all statin doses are given once daily, unless otherwise noted in the table. Also, the doses that are listed here are for patients with normal renal function and with no drug-drug interactions. So, depending on the statin that's used, the doses may need to be adjusted for renal compromise or for significant drug-drug interactions. Also, the doses and the drugs that are in red are FDA approved, but were not tested in the randomized controlled trials that were reviewed by the 2013 guideline authors. So who gets high-dose statin therapy, who gets moderate-dose statin therapy, and who gets low-dose statin therapy? This table shows what the 2013 guidelines recommend as far as the different categories of patients who will benefit from the different intensities of statin dosing. I should note that patients who are less than 21 years old, who have routine hemodialysis or have New York Heart Association class 2 to 4 heart failure were excluded from these recommendations because the authors of the guidelines didn't feel like there was enough representation of these patients to make these general recommendations. So as far as who to use these different intensities for, you can refer to the guidelines for more details. So statins are not without their potential side effects. Myopathies are a side effect that's often described as soreness, tiredness, or weakness in the muscles. And they may be mild or they may be severe enough to limit daily activities. Rhabdomyolysis is rare and it's more likely to occur with high doses of statins and when using statins with fibrates, which are another drug class, non-statin drug class that we'll talk about a little bit later. Also, patients may experience elevated hepatic transaminases. Usually, these are mild and it's not a problem. However, they may be more severe if patients present with myopathies and rhabdomyolysis. So we'll talk more about how to monitor these transaminases and how to manage this. Some patients will experience nausea or gas or diarrhea or constipation with statin use. These are rare and typically it occurs in patients who already have digestive issues. And to help prevent this, patients can take their medication with their evening meal. Rash or flushing has also been reported in patients that take statins. And then also statins can potentially increase blood glucose or cause type 2 diabetes, although the risk is very small. And we'll talk about how to manage this and how to screen for this as well. Memory loss or confusion has also been reported in patients who take statins. Typically, it will reverse when patients stop taking the statin. There's actually evidence that statins may help with dementia, just as kind of a counterpoint to this potential side effect. Now, there are some patients who are at greater risk of these side effects than others. Patients that are taking high doses, who are also taking fibrates with their statins. Females, patients with small body frames, older patients, or that have baseline kidney or liver disease. If patients have type 1 or type 2 diabetes or consume alcohol, more so in patients who are male and less than 65 as compared to women or men that are older. So we need to monitor safety and efficacy in our patients that are taking statins. So first we should check an alanine amniotransferase at baseline, and the guidelines really only recommend rechecking this level only if symptoms of hepatotoxicity occur. Also, we should document any pre-existing muscle symptoms before starting a statin in order to establish a baseline in case myopathies do develop while the patient is on a statin. We can consider checking a creatine kinase at baseline in patients who are at an increased risk for myopathies. So for example, maybe patients that are on a concurrent medication that has a drug-drug interaction with statins. And we only really need to repeat this level if the patient is symptomatic. And also because there is a risk of increasing blood glucose, we need to monitor for new onset diabetes in our patients that are on statins. After we put a patient on a statin, we should check a fasting lipid panel 4 to 12 weeks after the statin has been initiated. And then we can check that lipid panel every 3 to 12 months. If you do have a patient whose LDL drops less than is expected based on the intensity of dosing that you're using, it's very important to make sure that we first check adherence to the statin and then also check to see if the patient is following lifestyle interventions. We can consider lowering the statin dose if we have 2 consecutive LDL measurements that are less than 40. So the guidelines really stress that we need to manage side effects of statins in our patients in order to avoid any unnecessary discontinuation of the statin therapy. So if your patient presents with myopathies, you can hold the statin while you investigate the situation. If the patient is having severe myopathies and these myopathies are unexplained, then you should check a serum creatinine and do a urinalysis to rule out rhabdomyolysis. If the myopathies are mild to moderate, you should really evaluate for other conditions first, potentially any increase in physical activity that's causing these muscle pains, a primary muscle disorder, vitamin D deficiency, rheumatologic disorders, any hypothyroidism, and then any renal or hepatic dysfunction. So after you've held the statin, if a patient presents with myopathies, while you're investigating, if muscle symptoms resolve, then you can give the original dose of the statin and restart that, or restart them on a lower dose of the same statin. If symptoms begin again after restarting the statin, you should discontinue the original statin and begin a low dose of a different statin after the patient's symptoms have resolved. And then as the patient is on the new statin, you can increase that dose as tolerated. So if symptoms or elevated CK don't resolve after 2 months of the patient being off of the statin, you need to consider other causes. And if another cause is found and treated or resolved, then you can go ahead and resume that original statin at the original dose. So you should be screening your patients on statin therapy for new onset diabetes. If diabetes does develop, make sure that the patient adheres to a heart-healthy diet, physical activity, maintains a healthy body weight, and avoids smoking. You can continue statin therapy. If memory loss or confusion occurs in a patient who is on a statin, you should evaluate the patient for non-statin causes. Are there any other drugs that can be contributing to the memory loss or confusion? And are there any systemic or neuropsychiatric causes? If you determine that it is due to the statin, symptoms typically will resolve with discontinuation. Because many statins are metabolized by CYP3A4 or CYP2C9 isoenzymes, you have to be cautious when using statins with inhibitors or inducers of this enzyme. Some statins are contraindicated in patients on these other drugs, or you may have to modify the statin or the interacting drug to prevent any toxicities. There are a couple statins that are metabolized by other pathways, so they have fewer interactions and are safer to use if a CYP P450 inducer or inhibitor is required.
So when should we consider non-statin drug therapy in our patients? Well, the 2013 AHA guidelines did not recommend routine use of non-statin therapy, and the NLA guidelines did recommend non-statin therapy in certain scenarios. But since then, the American College of Cardiology published an expert consensus document that updated the 2013 AHA guidelines in terms of the role of non-statin therapies, specifically for LDL cholesterol lowering, which the NLA has endorsed. So the update notes that we should make sure that patients are adherent to lifestyle and to statin therapy, and re-emphasize adherence before we add a non-statin drug to the patient's regimen. But if a patient is adherent and then non-statin drug therapy is indicated when there is intolerance or a less than expected response to the statin. So if there is intolerance, this update recommends that we try certain strategies like using a lower dose or re-challenging the patient with a different statin, maybe 2 or 3 if we need to, with a different that uses different metabolic pathway. Also, we could try intermittent dosing of some of the longer half-life statins. So if we have patients that are high risk, meaning they have existing ASCVD or an LDL that's greater than or equal to 190 milligrams per deciliter, and they are on a max tolerated statin, but yet we still haven't seen at least a 50% reduction in their LDL cholesterol, then we can also consider adding a non-statin to their drug therapy regimen. The update does recommend that we consider factors such as drug-drug interactions of the additional therapy, the cost, convenience to the patient, pill burden, administration route, and the potential to jeopardize evidence-based therapies. So I think they are meaning statins in that case. And then, of course, importantly, patient preference to taking an additional medication. They also recommend that these patients might be helped with a referral to a lipid specialist and a registered dietitian, especially in patients that are very high risk and patients with familial hypercholesterolemia. So this table lists the non-statin drug therapy that's recommended by the expert consensus date on non-statin therapies for LDL cholesterol lowering. And the table on the left-hand column lists the drug class, and then followed by the drugs that are available in that class, the indication or when we would use them, and then the mechanism of action. And I just want to go through a couple of things on this slide to point out. Ezetimibe, or Zetia, is our steroid absorption inhibitor, and this is the agent that is recommended to consider in most patients as an addition to their statin for LDL reduction. And this is given its safety and tolerability, although studies have shown that it really only has modest efficacy. So, and if ezetimibe isn't tolerated, then the bile acid sequestrants, which are resins, those are recommended as second line to be added to the statin. A couple of things with this is that these medications can affect absorption of other medications that patients might be taking. So it's important to make sure that when they take these medications that it's separated by a couple hours from the administration of the other medications that patients are taking. It's not always well tolerated. Patients will complain that it's gritty because it's a resin. It can cause some gas and bloating just based on how it works in the intestine. And then it's also not appropriate to give in patients who have high triglycerides because it could worsen their triglycerides. And then our PCSK9 inhibitors. These are newer agents and they're monoclonal antibodies. And they have a unique mechanism of action that helps to decrease serum LDL. These are typically used if ezetimibe is not effective. So even with the addition of ezetimibe, you're still not getting the patient to the goals that you want to get to them. You could consider this medication. And then potentially you might choose this one first line to add to the statin over the ezetimibe if the patient has familial hypercholesteremia. So this one is administered by a sub-Q injection, so that's different from all the other medications that we've talked about, which have been oral agents. Pretty well tolerated. Some adverse drug reactions, really just mild injection site reactions and muscle aches. But the thing with this one that might be a barrier to entry with some people is the cost of the medication. So being a newer agent, being a monoclonal antibody, it is rather expensive. So this table of non-statin drug therapy is set up similar to the previous table with the class of drugs listed on the column on the left. So we'll start with fibrates. Fibrates don't show mortality benefits when given with statins to lower LDL, but they do demonstrate a significant benefit on triglycerides lowering in patients with very high triglycerides. So therefore, that's recommended by the NLA guidelines that if patients have very high triglycerides, greater than 1,000 milligrams per deciliter, or as an alternative to a statin, if triglycerides are between 500 and 999. So there are some potentially significant drug-drug interactions that may exist because these drugs are metabolized by CYP450 enzymes. So dose adjustment, close monitoring, or alternative therapy may be needed, especially if used concurrently with statins. Also, side effects can include myopathies and rhabdomyolysis, so it's important that patients report any muscle pain or weakness that they have, and fibrates can also increase the risk for gallstones. So omega-3 fatty acids are available as nutritional supplements, but they are also available as a prescription product. So I think it's important to note that supplements don't have the same FDA oversight as prescription products, so supplements may not contain the same amounts of the active ingredient. So I think that's important to note when recommending these in your patients. At very high doses, these agents can also significantly lower triglyceride levels in patients with very high triglycerides, but omega-3 fatty acids really have little role outside that population. To that end, the NLA guidelines have recommended them for triglyceride reduction if patients have very high triglycerides as well, greater than 1,000, or as an alternative to statins if triglycerides are between 500 and 999. One thing to note that is if your patients have a known allergy to fish or shellfish, they should avoid these products. And then lastly, niacin. It's also known to significantly decrease triglycerides and decrease LDL and has a potent effect on increasing HDL. But despite its effects on LDL and HDL, the AIM-HIGH trial did not show mortality benefits when adding to a statin. So NLA guidelines only recommend its use in treatment of very high triglycerides, similar to fibrates and omega-3 products. But since the NLA guidelines were published in 2014, the HPS2 Thrive study results came out, which also looked at niacin with statins' effect on clinical outcomes. And they similarly found no benefit, but the patients in the niacin group experienced statistically significantly higher rates of adverse effects, some of which had not been previously reported with niacin. So therefore, the 2016 American College of Cardiology update on the role of non-statin therapy does not recommend niacin as its use out. They believe that its use, the risks of its use outweigh benefits. This concludes the lecture on the pharmacotherapy of dyslipidemia. And I would encourage you to post any questions that you may have to our discussion board. Thanks.